Good morning, everybody. We'd like to get this morning session started. We have a very ambitious and tight schedule to stick to, so we're going to dive right in. My name is Dave Cohn. I'm the editor-in-chief of Academic Emergency Medicine, and it's a great honor to welcome you all to the 11th Journal Consensus Conference here in Phoenix. The book that you got at the registration desk lists the prior consensus conferences that the journal has run on behalf of the society. All have been very successful. We're sure this one will be as well. In a few minutes, we're going to bring up our co-chairs, Brendan Carr and Ricardo Martinez, to get things started, but I want to make a couple of very brief announcements before we do that. Page 9 and 10 of your spiral-bound book has the schedule for today. I implore the speakers and the panelists to keep things on time. It's a very ambitious agenda, as you can see. We don't have any wiggle room in there for extra time, so please, let's do our best to keep to the schedule as written here. I also want to remind everybody in the audience that this is your consensus conference. The purpose of the conference today is to define the research agenda that will move the science of regionalization of emergency health care forward. So please participate actively in the consensus building groups. There's 4 such groups this morning and 4 this afternoon. So you can go to 2 different topics, one in the morning, one in the afternoon. Please actively participate. Make sure you sign in at those sessions so we know who attended the breakout sessions. And it's those working groups, those 8 working groups, that are going to define the majority of the output of this conference in terms of the consensus on what that research agenda is. So please take a very active role. And all of the proceedings from this conference, which will be a mixture of the plenary sessions, the breakout group work, and original contributions that we've already received on the topic of regionalization, will appear in the December issue of Academic Emergency Medicine. And now I'd like to introduce Jill Barron, the current president of SAEM.
Thank you very much, Dave, and welcome to Phoenix. SAEM is extremely pleased to host and provide support for the 11th Annual Consensus Conference. The Society is exceedingly proud of its journal, Academic Emergency Medicine, and its outstanding track record in putting together these conferences, which have a very high impact on timely topics and creating a research agenda, and I'm sure today's conference will prove to be no exception. SAEM's mission is to lead the advancement of emergency care through education, research, advocacy, and professional development in academic emergency medicine. And one of the ways that we achieve that mission is to influence health policy through forums such as today's conference, through publications, and through intra-organizational collaboration. And to that end, I am very grateful that the American College of Emergency Physicians has partnered with the SAEM Regionalization Task Force this year to provide the leadership and structure to this conference, and in particular, I'd like to thank Brendan Carr and Ricardo Martinez for their collaborative leadership in that capacity. And we're very pleased that many of our ACEP colleagues, President Angela Gardner, and many board members are here today as conference participants. I would also like to acknowledge our federal partners who are in the audience today and thank them for their support, specifically Ryan Mutter from AHRQ, Drs. Robin Conway and Walter Korschetz from NINDS, and also participants from NHLBI and NICHD. Thanks must also go to ACEP for their generous financial support of the conference, as well as to the Emergency Department Practice Management Association, who also provided financial support. I'd like to welcome Randy Pilgrim and other members of the EDPMA board as conference participants as well. And finally, I would be remiss if I did not mention the money that was given to the conference from our generous colleagues in many academic departments of emergency medicine to the general operating expenses, to cover the general operating expenses of today's conference. So thank you to everyone, and I look forward to a very lively and interesting discussion.
I'd like to introduce the 2 co-chairs of the conference at this time. Brendan Carr from the University of Pennsylvania completed his training there and did a Robert Wood Johnson Clinical Scholars Program. And Brendan, I think Ricardo won't object too much if I say that Brendan has really been the driving force behind this entire project. I think he's done the lion's share of the work on pulling this together, and I think the success of today's event is going to be due primarily to his hard work. Ricardo Martinez from Emory University is serving as his co-chair. I'm going to turn things over to them now.
Good morning, everyone. Thanks so much for being here. I'm Brendan Carr from the University of Pennsylvania. This is Dr. Ricardo Martinez. We're conference co-chairs for the day. I know that we started with a lot of thanks, but I want to add to them some essential names that were left off the list because they largely function behind the scenes, but they're the reason that we're all actually here today getting this done. From the Academic Emergency Medicine Office and the SAEM Office, and SAM office. I want to thank Sandy, Neil, Barb, Marianne, Janet, Gina Marie, Kathleen. Truly, without them, things couldn't have gotten started today. I know Dave said it, but I'm going to unfortunately say it one more time. Please participate and please help us to stay on schedule.
Yeah, just my quick comments to make is that we are kind of fast-paced. We will be very tough taskmasters. We do appreciate your participation, and I really want to thank all of the organizations that came together to make this a reality.
Thank you, sir. Thank you. With that, it is my pleasure to introduce our first speaker. Our first speaker is Steve Epstein. Steve Epstein is an emergency physician at Beth Israel Deaconess. He was the lead author on the ACEP report card, which he's going to talk about for us today. His primary area of research is in crowding and solutions to crowding. He is here. That worried me when he wasn't in his seat. He has become a good friend and has been a great help for us putting this conference together today. So thanks very much, Steve. We are hoping that he will, in the next hour, we will get the backdrop of sort of how we came to be in this room today, talking about the future. So we are very briefly going to catch everybody up who has not been reading about this debate on what has happened over the last 30 years.
Okay, technology is grand. Let's see, there we go. Okay. So I was asked to talk a little bit about the ACEP report card, and when Brendan asked me to talk a little bit about it and how it related to regionalization, I had to think about it because the report card was not actually designed as a regionalization document. And it's not just me putting together. I just want to thank these are the members of the task force. There are lots of other people who helped out with this, but it was through their work and dedication that we actually came up with this report that I'm going to talk to you a little bit about today. The National Report Card Project started in 2007. It was the second edition. There was one that was put out in 2006. From 2007 to 2008, we restructured exactly what data we were going to collect so that we could collectively push a button in July of 2008 when we did it, collect all of the data, and then start to write this up into a report that was released in January 2009. The report card is really designed to evaluate the conditions under which emergency care is delivered. It is not to tell you that your emergency department, your local community doesn't do a good job or does do a good job. It's really looking at state policies that are in place to support emergency care. And in that way, it can be used as a tool by states to determine where they sort of sit on the curve nationally. All of the metrics that we used in the report card, and there were 116 of them, needed to be chosen for relevance, reliability, validity, consistency across all 50 states, and currency. And it was the consistency across the states that actually proved to be one of the more problematic areas. There are a lot of national databases out there, but when you start looking at questions about emergency department crowding and boarding, for instance, which we were very interested in, there really are no national databases. So one of the things that we did do was partner with the State and Territorial Injury Prevention Directors Association. It was through their work, they do a survey each year of their membership, that we were able to collect some additional metrics that are not otherwise available in standard national databases. The report card was divided into 5 major areas: access to care, quality and patient safety environment, public health and injury prevention, liability environment, and disaster preparedness. And of those, there are really 3 that speak to regionalization: access to care, the quality and patient safety environment, and disaster preparedness. And we could talk about the liability environment, and I could tell you a lot about the distribution of attorneys in the nation, but that's for another day. When I looked at what regionalization was, and I think that's going to be one of the major challenges of the day today, we don't really have a great definition. We know that it's getting the right resources to the right patient at the right time in a region. But define what a region is, define what the resources are, which can include material, personnel, just knowledge. We talk frequently that regionalization is not necessarily centralization. It's not a funnel that we're going to take all the patients from community hospitals and funnel them to large tertiary centers, but needs to be thought of more as a web, more as a collaboration. So many of the report card metrics actually can apply to regionalization. And we're going to talk a little bit about some of the metrics that are used within states, which are largely speaking to planning and coordination, and some of the national distribution of personnel and infrastructure when we actually are able to compare the states. And I want to mention the rural and frontier areas as well. We looked fairly carefully at these, largely because of geography and population. They can be a lot more challenging to develop networks of care in those areas. But when you look at the report cards, some rural states, such as North Dakota, Nebraska, and West Virginia, actually fared pretty well, while California and Florida fared relatively poorly. So that is not necessarily saying that a rural state can't have good regionalization or do well in the report card. These were the overall results for the report card. The grades range from a B in Massachusetts down to a D minus. Arizona, where we are right now, is D plus, ranked 40th in the nation. And looking at those three subject areas that we talked about, access to emergency care, you can begin to see the large disparities around the nation. We divided each one of these larger categories into subcategories. So this is looking at access to providers, treatment centers, hospital capacity, and financial barriers to care. When you look at the quality and patient safety environment, again, a lot of disparities, but you'll see the disparities are in different locations. And then finally, looking at disaster preparedness, again, you can see sort of the same thing with grades ranging all the way from A to F. And what that's really saying is that there's a huge spread around the nation in what various states are doing. There's no real gold standard. So the states that scored the highest were given an A, and then it was scaled down from there. And the national grades were determined as a population-weighted average of the states. The report card ended with two recommendations that are applicable to regionalization, calling for greater coordination of emergency services and enhancing the quality and patient safety through systems, standards, and information technology. And I know there'll be some panels later today on all of those points. Looking at the state regionalization metrics in the report card, with an access to emergency care, we asked one question about the population within 60 minutes of a level 1 or level 2 trauma center. And the average was 76% across the states, but that varied from 11% of your population to 100%. And again, think about rural areas. You know, if you think about the state of Wyoming, for instance, a lot of the population may be in Cheyenne. So if they have one major trauma center, they still could do quite well in that type of metric. Within the quality and patient safety environment, we looked at the counties that had E911, something that speaks to the infrastructure that's available. Average was 94%, but ranged from 52% to 100%. And we looked at some very classic regionalization projects, stroke systems of care and STEMI AMI systems of care. And while 43 of the 50 states are working on, this doesn't necessarily mean they have to have it. We asked, do you have it or are you working on it, a stroke system of care? But only 29 are looking at how they're going to take care of STEMI. For disaster preparedness, we had a whole lot of metrics going to coordination and planning. And while most of the states, as you can see, at least have some sort of a disaster plan, I think they need to have that in order to get some of the federal funding. You can look at some of these other metrics, statewide patient and victim tracking systems down on the left there. Only 22 states are going to be able to track patients in case of a disaster. They actually have a plan to do that. 18 of the 50 are able to track victims. Only 33 have a written plan for how they're going to coordinate security for the hospitals in case of a disaster. And, you know, sort of in the upper 30s here for any type of syndromic surveillance, looking at ED presentation so that they can actually pick up, say, a bioterrorism attack. And 38 have some type of medical assistance or strike team that can actually go out into the more rural areas or frontier areas and assist communities. Looking at the national regionalization metrics, these are largely speaking to the distribution of resources around the country. And I've divided this up into personnel and infrastructure. When we look at emergency physicians per 100,000 population, and this is self-reported, this is not board certified, this is self-reported emergency physicians from the AMA master file. We have 11.8 per 100,000, but it ranges fivefold, from 5 to 25. Neurosurgeons range fivefold, from 1 to 5.2. Plastic surgeons range sevenfold. I mean, you could see the rest. The RNs are more than twofold, and the number of primary care FTEs needed in a state varies from 2 to 756. In terms of infrastructure, we're also a very lumpy nation, I guess you would say. We've got an average of 20 EDs per million population, but it ranges from 7 to 66. Inpatient beds, now these are staffed inpatient beds, so these are beds that are actually available with nursing resources, range from 208 to 892. Psych beds from 8 to 55. Hospital occupancy per 100 staff beds on average 67%, ranging from 56 to 85. And a note on that one, when we were looking at crowding in Massachusetts, we asked our DPH to take a look at our hospital occupancy, and they said it was about 65%. And we said, you're crazy. And the issue is, and it's probably true in a lot of states, that hospital occupancy is generally measured at midnight. And if you measure it at noon, you'll find that your occupancy is actually quite a bit higher. That's what we did, and we discovered in Massachusetts it was closer to 90%. You can see there's great variation in hospitals that actually have electronic medical records. Hopefully that will be improving shortly with meaningful use requirements. And only 25% of the states were actually collecting any type of data on diversion used as a marker for their work on crowding. So we got a lot of problems out there, and it's probably just the tip of the iceberg. Very briefly, I'm just going to share with you some of the data that comes from the Office of Statewide Health Planning and Development from the state of California. I did a talk on California, and this is some data that comes from them on medically underserved areas and populations and primary care shortages. So you can see that there are large swaths of the state. This is for mental health that do not have adequate providers, and this is based on percentage of population and geography. How far away are you from a provider? This is their nursing shortage, 47th in the nation from California. But again, you can see Southern California has a real shortage, while the North seems to be doing quite a bit better. This is primary care, where they're next to last in the nation. They need over 500 FTEs of primary care providers, which they don't have. And this is the primary care shortage areas, everything that's shaded there. So you can see there's a great lack of primary care. And this is just California. But you can see even within California, there are disparities within the state, within certain geographic areas, where we have primary care, where we don't have primary care, and primarily, obviously, they're in the larger metropolitan areas, and the rural areas are underserved. So from the report card, we might conclude that there are wide disparities within the states and among the states in planning, personnel, and infrastructure. And effective regionalization is going to require either additional resources or a redistribution of the current resources we have within and among the states. And with that, we have a lot of work to do, and I'll turn it back over to Brendan. This is going to make a very loud buzzing noise for a sec, I fear.
Thank you so much, Steve. It's now my great pleasure to introduce Brent Asplund. Brent is chair at Mayo of Emergency Medicine and is sort of, I think, an efficiency expert, very interested in hospital flow and how we do what we do better. He was on the initial report that wrote the 2006 Future of Emergency Care, the original committee that wrote the 2006 Future of Emergency Care report out of the IOM, and we asked him today to spend some time sharing with us some stories from that report, that wonderful 3 years they spent in committee, and maybe a little bit begin to lead into the conversation that has happened after that. Thanks so much.
Thank you, Brennan. Good morning, everyone. It's good to be here with you. And what I'd like to do for the next few minutes is basically go over the rationale for the 2006 reports, cover some of the key findings, and focus really specifically on the vision for the future of emergency care, and then spend a few minutes talking about the progress we've made. So those are my goals. In 2006, on June 14th, this was one of 3 reports released, Hospital-Based Emergency Care at the Breaking Point. And the rationale for these 3 committee reports from the Institute of Medicine and the goals of the committee were really to look at all aspects of emergency care in the U.S. health system. Not emergency medicine, but emergency care in the U.S. health system, to look at the strengths and weaknesses of emergency care as it exists today, to outline a future vision for where emergency care should go, and then make recommendations about how to achieve that vision. The overall committee was chaired by Gail Warden, and there were 3 subcommittees, one on pediatric emergency care, one on pre-hospital EMS, and the hospital-based emergency care subcommittee. So that was the structure and the rationale for the IOM reports. In June of 2006, what did we find? Well, this list is not going to come as a shocking surprise to this audience. Certainly, crowding and diversion was one of the key findings, and one of the key recommendations was to eliminate crowding and diversion. Unfortunately, it didn't disappear on June 15, 2006, and we still have some work to go, although progress has been made. But if you focus in on the next 3 key findings, I think that really speaks to why we're in the room today. We talked about fragmentation and limited coordination of the regional flow of patients, a lack of system accountability, particularly as it speaks to that regional flow of patients, and an insufficient research base. So just think about those 3 key findings and our work today, and I think that really outlines the work that we have cut out for us as far as understanding how to better coordinate that regional flow of patients, make the system more accountable through important performance measures, and also developing the research base. In addition, comments about inadequate emergency preparedness, the on-call crisis, and uncompensated care were also found in the report. The vision really focused around 3 key principles, and that was regionalization, coordination, and accountability. And those were the pillars, if you will, of what the committee felt would be the best direction for the future of emergency care in the U.S. health system. Well, what have we done since 2006, and what is the progress? In a word, what's a word from out here? There's a few options. I would say mixed. I would say mixed. On one hand, just in the last couple of years, you have reports coming from Congress and the Committee on Oversight talking about inadequate preparedness for the emergency care system to respond in crisis. In addition, the GAO released an update from its 2003 report that highlighted crowding and delays in boarding in emergency departments across the country. An update was released last year in April, about a year ago, that says that some of the sickest emergency department patients are waiting twice the recommended waiting time. So from the standpoint of crowding and diversion disappearing, it didn't quite happen. But on the other hand, let's take a look at 3 of the key recommendations from the Institute of Medicine. One was that they called on Congress to establish a demonstration program to promote regionalized, coordinated, and accountable emergency care services. And in a minute, we'll hear from Dr. Michael Handrigan, but those demonstration projects and demonstration contracts are now unfolding. They're under review. The applicants have submitted their proposals, and the Emergency Care Coordination Center will be overseeing demonstration grants that will start this summer or this fall. In addition, they called on federal agencies to look at evidence-based categorization systems, pre-hospital protocols, and indicators of system performance. Well, there is a number of different groups that are looking at not only related to regionalization, but also specifically categorization. There's an ACEP task force on categorization. It's a very challenging topic, and I think you'll hear a theme throughout the day is that categorization is certainly not enough to accomplish our regionalization goals, but there is work in progress being made in trying to sort those issues out. And finally, they called on Congress to establish a lead agency in the Department of Health and Human Services for emergency and trauma care. And if you look at the cooperation between the Emergency Care Coordination Center and the Federal Interagency Committee on EMS and how they have convened the Council on Emergency Care quarterly, representatives from essentially all the federal entities that have some oversight responsibility for some aspect of emergency care meet in D.C. to make sure that the approach to these emergency care issues are coordinated across the federal government. So I think there's significant progress that's being made in this area as well. Looking at the Emergency Care Coordination Center in this timeline, I've specifically mentioned the drivers of the reports from the Institute of Medicine, and then in 2006, the release of the AEM report. There was a working group that was started in late 2006, and then one of the Homeland Security presidential directives called for the establishment of an Emergency Care Coordination Center, which subsequently was established, and today is really, I think, at a critical moment, and I think it will be one of the key entities that we all need to work with to help realize the vision and to help realize the work that we're outlining today. So the Emergency Care Coordination Center will be, I think, a key entity for if we're going to make any progress on regionalization moving forward. One of the most important follow-up events that occurred vis-a-vis regionalization emergency care was last September, the Institute of Medicine workshop on regionalizing emergency care. And the objectives of this were really to foster some information exchange between the federal officials involved in the topic of regionalization, along with key stakeholders from a wide range of areas across the country. The goals were to learn from the past experience and the current efforts, and also to consider policy efforts that could help promote regionalization across the country. They looked at the overview of the trauma systems and looked at lessons learned from other systems as well. They described potential pitfalls of regionalization, key issues for the future as far as making progress, and then to provide a written summary, which is now available at the National Academy of Sciences website. So I would encourage you to take a look at that. And actually, on page 12 of your handout, there are some key quotes from the Emergency Care Regionalization Workshop. One thing to keep in mind is that as opposed to the Institute of Medicine committee, a workshop is not a consensus committee. In fact, there are no summary recommendations that come out of an Institute of Medicine workshop, and the written document is meant to capture what was said during the proceedings, not to come to some consensus about what to do next. Their attendees are invited not because of who they are, but to represent their interest group, and the idea is to exchange as much information as possible to move forward. So I'm just going to, in that spirit, highlight a few of the speakers from the regionalization workshops, and several of the people in the room participated and can add to this throughout the day in addition to the quotes that you have in your syllabus. But looking at the trauma system as one model for regionalization, certainly, as Ellen McKenzie pointed out, treating major trauma has been shown to be cost-effective and make a difference from an outcome perspective. There's been tremendous progress in the trauma system, but there's still variability in that progress if you look across the country. But a couple of key themes. Regionalization is not centralization. That's a key learning from the trauma system development process. And categorization is not enough. And then the final one, which I'll highlight again, is that systems must be held accountable for performance, but we need good performance measures. And I think if there's one product from today, would be improved performance measures around this concept of regionalization. So those are some of the themes that I think will be important. If you look at one of the best examples of regionalization in a healthcare system, it would be the VA system under Ken Kaiser's leadership. And he pointed out that some of the reasons and rationale for regionalization include the need for complex high-risk conditions that really require a high intensity of care, where the resources are not available everywhere, limited availability of key aspects or key technological or personnel resources, a demonstrated quality of care benefit, like I just mentioned for major trauma patients, there's a demonstrated benefit of going to a level 1 trauma center for major trauma patients. When there's a continuum of care that's needed across the system, if you can make a case from a cost or quality perspective, that's a driver and a reason to pursue regionalization. And finally, when you can demonstrate economies of scale, that's another rationale for moving towards a regionalized and coordinated system. But on the other side of the coin, again from Ken, looking at lessons learned, is that it's much more difficult and complicated than we would expect. And I think that highlights one of the reasons why, although we've made some progress, today we would not find that we have a regionalized, coordinated, and accountable emergency care system everywhere in the United States. Medical leadership is crucial. The financial impacts are often misunderstood. I think this is a critical issue, and if we do not address the economic incentives and disincentives for regionalization in a forthright way, we are going to have a very difficult time making progress. One of the participants was Dr. Alex Zavalatka, who is a neurosurgeon. Again, the theme, regionalization is not centralization. He spoke a little bit to the problem of over-triage by sending hospitals and what that drives from a system perspective. And I think that's an important theme because of the two-way nature of regionalization, and that we don't have to create a funnel to the tertiary centers. In fact, that would be the wrong approach, and that we want to make sure that we support other hospitals across the system to keep patients at the local level when it's appropriate. And again, pointing out the need for better data about who, when, and where should patients go and why. Some examples of systems that are working reasonably well, a presentation by Joe Acker from Birmingham, really talking about the parts of the system that they have in place to really create, in some respects, better system awareness and patient routing and monitoring of the data performance. And one example of an area, that, at least from a pre-hospital perspective, that has a good coordinated, regionalized, and accountable system. So what are the key conclusions from the workshop? The historical approach has been just send us all your bad stuff to us, and then we have a regionalized system. And it doesn't work in competitive markets. And many of the reasons for that non-acceptance of that model is the cost competition in competitive markets across the country today, and that the referral hospitals are concerned that they're really not going to have the key patients that support their bottom line. And that's why, again, I think the economic interests are really critical. One of the key challenges is that smaller hospitals give up the paying patients, whereas referral centers often worry about the fact that we're getting too many of the quote-unquote wrong types of patients from a financing perspective. And I think we just need to throw that out on the table and talk about it and wrestle with those issues today in order to make progress on regionalization. Otherwise, we will continue to try to push an approach that likely will be unsuccessful. I'd like to just highlight a few key questions before I close. And one of these was alluded to by Stephen, and that is, assuming a variety of local models, what are the defining characteristics of a regionalized emergency care system? In some respects, this is the what is it question, and we spent many hours debating how prescriptive and detailed to be about what a regionalized system should look like. We decided not to take a very prescriptive approach in the AEM committee because what would work in Montana probably wouldn't work in South Florida. But if the structure isn't the defining characteristic, what characteristics are the defining characteristics of an emergency care system? What are the key performance indicators? To whom should these emergency care systems be accountable? I think that's a key question. It ties into the types of performance indicators one would suggest. How should we manage the tension between disease-based versus generic regionalized systems? Trauma. Are we going to create a system for trauma, stroke, STEMI, et cetera, or versus a generic system? And I think that tension is going to be important to wrestle with. And then finally, how can the development of regionalized emergency care systems be integrated with and best coordinated with implementation of healthcare reform? Because if you look at the Department of Health and Human Services, this is going to be a key challenge moving forward. And the more we can coordinate with the Emergency Care Coordination Center and build our efforts about building a regionalized emergency care system into the implementation of healthcare reform, I think we will have more momentum in Washington. And I think that'll be an important aspect. If all else fails, we can just ask these 7 guys in the world's busiest control tower to take care of this system for us. One of my favorite people on the Institute of Medicine committee was Brent Eastman, a former leader, initial leader in the American College of Surgeons Committee on Trauma. And one time during our debates, he leaned back in his chair and he said, just remember, there's a fine line between a vision and a hallucination. And sometimes that's what it felt like. Hopefully we had more of a vision than a hallucination. But today, and with this group, the best way to predict the future is to create it. I think we'll make some significant progress. Thank you.
Thanks, Brent. Thanks very much. What I'd like to do is go into the next portion for us, which is really the federal perspective. Bringing that to us, our two speakers today, Dr. Mike Handrigan from the EEEC. You want to come up, Mike? I got this right, huh? Good. We have both of these docs are emergency physicians who have made their mark in the federal aspect of things. Dr. Mike Handrigan is with the EEEC that you heard Brent refer to earlier. It is now up and running, started by one of our other colleagues. It is in ASPR, which is in the Secretary of Health's offices, in an area that has become increasingly important for us. Dr. Handrigan is actually a researcher by background in hemorrhagic shock, and has done so in the military, both the U.S. Navy and the Army, and is also was with the AHRQ. So we appreciate him very much. Dr. Marcosi is an emergency physician also, is a Philadelphia boy, was at Duke, and set up the disaster center at Duke, and was asked to go from there to work in the Senate, where he focused on disaster preparedness. He became the author, while working in the Senate, for the Pandemic and All Hazards Prevention Act, also known as PAPA, after it was passed, which explains why he keeps saying, "Who's your daddy?" all the time. And is currently with in the national security staff in the White House. Both of them will present to us and give us the federal perspective. And if we have time, they'll be able to take some questions. Thank you.
Thanks, Rick. We'll jump right in. Let me first preface by the asterisks. These are my remarks, not the administration's policy. So quickly, you're wondering what the national security staff is doing here at SAEM. I'm going to see if I can bridge that gap and bring you all up to speed on what we're doing at the national security staff and how it applies to regionalization. In the Executive Office of the President, there are multiple different councils and other offices. One of them prior was the National Security Council, now called the National Security Staff. The council was established under President Truman, and the members to that council are the principals in the federal government. It was reorganized in 1949, and it was placed within the Executive Office of the President, where it currently sits. Prior to 2009, there was a National Security Council and a Homeland Security Council. The Homeland Security Council dealt with domestic issues. The National Security Council predominantly dealt with international issues. As a result of the new administration and the concerns in and around those two entities being separate and distinct, in 2009, the President put together PSD1, and the conclusion of that study was that the councils should be merged. Currently, General Jones is the National Security Advisor and the Assistant to the President for National Security Matters. My boss is in the lower right, Mr. John Brennan. He is the Assistant to the Assistant to the President on Homeland Security issues and security and counterterrorism. This is a complex organizational chart, but you put two bodies together that were separate and distinct, flattened the organization, and attempted to bring some unity and consistency to the organizational flow. The lower right aspect is the is the Office of Resilience. Under that sits a preparedness and response sub-offices. Resilience is the buzzword. What we talk about in our office internally is how fast you get up from taking a punch. I mentioned that there is a preparedness and response policy sub-offices under the Resilience Directorate. During an event, those two offices are merged, and we respond in coordination and support our other Executive Office of the President and other departments and agencies in trying to coordinate interagency flow. What does our directorate do? It serves Mr. Brennan and his deputy Heidi Avery in trying to establish what the preparedness and response policy issues are, find some resolution there, and at times become operational. There are many portfolios. This is where the federal speak starts to translate into what we're doing here. One of those portfolios is the All Hazards Public Health and Medical Preparedness portfolio. I actually send regards from Mr. Richard Reed. He is prior a social worker in a hospital. Prior to that, his background was he was an Army Ranger. So his spectrum and what he understands from boots on the ground to what we're doing here, and he actually sends special regards, and I wouldn't be here without his support. This is the bread and butter slide, and my last slide. We all know how policy flows through the legislative side of government. This is how policy flows through the executive side of government. What happens is that there are interagency policy committees. The interagency policy committees are representation from DOD, DHS, HHS, VA, across the interagency, Department of Transportation, come to the White House when then there are policy issues that need to be vetted and decisions need to be made. The IPCs have sub-IPCs. The sub-IPCs are listed there. They stand up when there are issues to be addressed. The flow when there is a policy issue on the executive side of government happens at the sub-IPC level. It's usually convened when there is an issue, say for instance, the revision and a new way to think about preparedness, which is one of the things we're grappling with right now within HSPD 8. Federal speak, Homeland Security Presidential 8, Presidential Directive 8, looked at where we were with preparedness planning and actually tried to make it, we're trying to make it more capabilities focused. That is a policy direction and a new policy direction from the IPC that is in charge of that, and hopefully soon we'll have some way to proceed with regard to capabilities planning, which is where we are now, is scenario-based planning. So, the Domestic Readiness Group is in charge of that. One of the sub-IPCs under that is biodefense. I stand at the lead for the chemical defense sub-IPC and the lead for the IND preparedness and response sub-IPC. So nuclear detonation are certainly in our sub-IPC's lane, and also chemical defense. So let's just make sure we all understand this. Policy flows to the sub-IPCs. It is then vetted. If we are not able to come to a conclusion, it then moves to the DRG, which is an IPC level. So from sub-IPC to IPC. If the DRG thinks that it is the right way to go and two thumbs up, or if there is equivocal decisions and we are not able to come as an interagency body to consensus, then it moves to deputies and principals. Principals are secretary-level personnel. So the secretaries of HHS, these meetings are typically chaired within the White House Situation Room, and they are chaired by Mr. Brennan, typically. So policy flows sub-IPC, IPC to deputies to principals. That is how policy moves. The reason why I am here today is for two reasons. One, to listen, because we think that this is an important endeavor, and regionalization not only impacts what we do from an emergency preparedness standpoint, but what we do when we deliver daily emergency care. And they are intimately linked. So the ECCC is that linkage between the way we think about in the National Security Staff emergency preparedness and that daily delivery of care. If we strengthen the ability to deliver daily emergency care, we strengthen the ability of our nation and the resilience of our nation to respond to disasters. So I'll turn it over to Mike Handrigan, the current director of the ECCC, for follow-on.
So good morning, and thanks, Marco. Let me start by thanking Brendan and Ricardo for inviting us to participate in today's meeting. This is really an exciting meeting, and I think is going to have a profound effect on how we conduct business in emergency care. So I'm really grateful to have the opportunity to participate in this. I want to spend a couple of minutes. My time is short, and I'm going to try to limit my comments, but I want to tell you a little bit about the ECCC, the Emergency Care Coordination Center, how we do business, what we've been doing for the last year or so, how we have been working on regionalized emergency care as an issue, and then I want to tell you about 3 specific things that we're pretty excited about in the healthcare reform language, and how that may relate to you as a partner. So the Emergency Care Coordination Center, as Brent very well described, was created really in response to the IOM report. Following the IOM report in 2006, HHS put an expert panel together to deliberate the recommendations from the IOM and how to implement them in policy and programmatically. And what came from that was the Homeland Presidential Security Directive number 21. And one of the paragraphs within the HSPD 21 directed the Secretary of Health and Human Services to establish the ECCC, the office. The ECCC really represents a seed, a neonate, that may be able to grow into what the IOM called for in terms of a lead federal agency. It's going to take a lot of work. We have a long way to go to get there. But I think that this is really an important opportunity, not only for the federal government to create a focus for issues around emergency care, but it's an enormous opportunity for the stakeholders of emergency care, including yourselves. So how do we do business in the ECCC? We're a relatively small shop right now, but we have reach across the entire federal government. And as Brent described, we have established something called the Council for Emergency Care, the CEMC. And those are the folks out in CDC and NIH and DHS and DOD and DOT, anyone in the federal government that is engaged programmatically or policy-wise in emergency care comes together in this council. So that is the ECCC's opportunity to find leverage points where we can align programs across departments to make sure that we're working in the right direction, that we're not wasting resources or conflicting resources, and provide an opportunity for the various programs across the government to really guide our priorities, what we're thinking about, what we're doing, to get expert input from across the government, but also have the opportunity to bring those experts together. It's really a very exciting time in the federal government for emergency care. This has never really existed in the federal government before, as you know. There's lots of reasons for that, but I'm really happy to report that the CEMC and the ECCC are well on the way to establish a new paradigm for emergency care within the federal government. The next challenge, of course, is how does emergency care fit into the overall healthcare reform agenda, and we'll be looking for your thoughts and input about how we can best make those steps. So one of the first things that we did when we established the ECCC and got the charter signed, thanks to Dr. Marcosi, was to break out the marching orders from the IOM, look back at 2006 and say, okay, what are we supposed to do now? And it said, as you know, regionalized, coordinated, and accountable. Okay, we said, we're on the way. But wait a minute. I understand coordinated, but what about that regionalization thing, and what about the accountability thing? So we immediately reconvened the IOM for the follow-up conference. We asked them to specifically look at three things. We asked them to examine the state of the emergency care enterprise from 2006 to 2009. How far have we come? Where are we now? And what are some of the things that we should be thinking about? We also asked them to look at surge capacity, which is an enormous issue. The ECCC lives at ASPR, the Assistant Secretary for Preparedness and Response, for a very good reason. The emergency care infrastructure, the enterprise, is a critical component of how the country responds to, prepares for, and recovers from catastrophic events. So surge capacity within the emergency care system, as you know, this is no surprise, is really critical to us. The third thing that we asked the IOM to look at was this concept of regionalization, to help us understand, if not the answers, some better questions. I was talking to a bunch of cardiologists at the American Heart Association a few days ago, and I told them, listen, we have no idea what regionalization is. We need to understand it better. And later on, somebody ran up and said, where's Handrigan? Because if he doesn't know what regionalization is, we're in big trouble. The point I was trying to make there is that lots of stovepiped, disease-oriented structures are in place. Lots of people have good answers for what is regionalization. What we need are better questions. What we need are answers to how can we bring these stovepiped structures, systems together. How do we develop a system of emergency care that meets the needs for a region? So to Brent's question about is regionalization really a structure or is it a process? From my perspective, it's more about the process of bringing partners together at a local region in local areas to meet the needs and the requirements locally. It's about the resource utilization locally, the partnerships and dependencies that occur. We do know from the IOM conference and a follow-up stakeholder conference that we conducted that there are plenty of upsides to the concept of regionalization. We know that we can make better use of resources. We can probably train folks better. We can integrate communities. We can develop resilience. We also know that there's lots of potential downsides to what we may consider regionalization. If we look at regionalization as a game with winners and losers, that probably is going to be a non-starter from the beginning. So over the last year, we have been developing a demonstration program, and this is in advance of the health reform language that I'll come to in a minute. We've been developing a program to establish better questions about regionalization so that we can understand it. We really want to understand what the components of good regionalized systems are. So the best practices for regionalized care. What are the information management needs for regionalized care? And what are the patient movement needs for regionalized care? And what's the value proposition for regionalized care? If we're going to embark on this and promote it as a national enterprise, we really need to understand what are we getting into? What are we expecting from it? What are the downsides? And how do we mitigate the downsides before we begin the process? So that's what the ECCC has been doing for the last year. So now the health reform language. There are three very important things that I want to share with you that many of you probably already know about reading through the health reform bill. The bill speaks to emergency care in some very important ways, and to ASPR and the ECCC in very important ways. It brought the trauma program from HRSA down to ASPR, and it changed the language from strictly dedicated to trauma issues to establish a grant and contract program for emergency care and trauma systems. So that is what we're all talking about. Separately, it provided ASPR the authorization, the authority, to conduct grant and contract programs specific to regionalized emergency care, which is why we're here today. And then thirdly, and not specifically to ASPR, but to the Secretary of Health generally, it instructed the Secretary of Health to commit more effort to emergency care research, which is really, I think, critical. If we're going to improve the system of emergency care, we need to do it intelligently. The folks at the IOM speak about a learning healthcare system. Well, one of the critical and unique components of the healthcare system is the emergency care system. And we need a critically learning emergency care system within the healthcare system that is connected, integrated, and works in both directions, not just from the door to the ER to the back door of the hospital. So with that, I'm going to close. I'd be happy to take a question or two or leave that to the end. I'll leave that up to Ricardo. But thanks so much for including us in this process, and I'm really looking forward to the outcome and the agenda that is developed today.
If someone has a burning question while I set this up, we could take one or two for our federal partners here. Otherwise, we will keep moving. And please use them over the course of the day. They have very clearly said that they are very interested in this issue, and they very much want to be engaged in it, want to listen, and want to hear what you guys have to say, because the outcome of this conference will, in many ways, help them to navigate the future, I think. Where are you, sir? So it's my great pleasure now to introduce my co-chair to talk to us. Rick Martinez has done it all in his short career. He's an ex-administrator of National Highway Traffic Safety Administration. He's faculty at Emory, and he also works in the private sector for the Schumacher Group as a vice president of the operations in the East. As the president of the operations of the East and the vice president for medical affairs. He has been extraordinarily helpful to me over the course of the last year as we've been planning this thing, helping to connect me at all times to the resources that I needed, whether they be in the academic realm, the federal, the government realm, or in the private sector. He is talking to us today, sort of a modified talk of the talk that he gave at the Institute of Medicine's regionalization workshop meeting, hoping to help us to understand how we might want to change the direction of regionalization. We called the conference Beyond Regionalization because we're hoping to take a next step. We're hoping for better uptake than we've had historically. Thank you very much, sir, for speaking to us today.
Well, thank you very much, and I'm hoping I can go through this quickly and kind of bring us back on schedule a little bit. But I want to say two things. One is there is a certain humor in being former administrator and co-chairing this with a guy named Carr. I just think that's kind of a nice one. Secondly, you know, in my role, I've been around for a while, and early on in my career, I was part of the preventable death studies looking at the need for trauma systems, and was out in California with Trunky and Lewis and those guys. And so, you know, I've always worked in level 1 trauma centers, but I've also worked in rural facilities, and worked in rural Louisiana. And now in my current role, I actually oversee about 100 practices that are in large centers, the level 1 trauma centers, level 2 trauma centers, level 3 trauma centers, and even small rural facilities. So what you have is a perspective, and so what I want to do is share with you kind of the perspective of from those early days to where we are now, and then some of the changes and maybe some opportunities that we can use this meeting to help us move to the next level. Now, I will tell you, I always look at things very simply. This goes back from years ago. Where are we now? Where do we want to go, and how will we get there? So, you know, I told the story at the IOM, but it's a true story. I actually had to be on a webinar at 12:30. My flight arrived at 11:45. I got off the plane, went to the shuttle bus. I took the shuttle to my car, ran over there, and they have to give you a little piece of paper that tells you whether you parked in covered or uncovered parking, because there's a difference of about $3 a day, and I've been gone for a long time. So I got the little piece of paper, opened up my car, threw my luggage in the back, threw my bag in the back, went in, took my coat off, got up in the seat, started to turn on the car, and could not find that stupid piece of paper. So I stopped. I started looking underneath the car, got in the back seat, looked at my coat pockets, trying to find a thing, because I was really focused on getting to that meeting, because I had to be online for a webinar. Got outside, opened my luggage, couldn't see it, saw the lady in the shuttle, knew she had my piece of paper, started waving at her to get her to come back over here, because I needed that piece of paper. Went back down, she's coming, I don't see her, she's coming, maybe she's got my piece of paper. I jump up again, now it's beginning to rain. I look underneath the car, I'm down on my hands and knees underneath the car, open the back seat again, look under the front seats, and then she drives up, and just when she drove up, and I started to yell to her, I realized where that piece of paper was. And I took a picture with my BlackBerry. This is arm length at my BlackBerry. You can see the shuttle behind me. And I thought to myself, wow, you know, sometimes you can't see what's literally in front of your face. Now I noticed, by the way, that I was a hard time seeing down because that thing was blocking my vision, okay? So that happens to us, and I've told this story to people. Many people have told me about they do this with cell phones all the time. They're looking for it while they're talking to somebody, and they forget. So, you know, we have to remember that sometimes our focus drives what we do, and sometimes it means we don't see the other things. We don't gather those ideas. And so that's the idea of a meeting like this. We can come back and say, what are we doing, and how can we sit back and say, where are we now? And what can we do in the future? So the driving force of regionalization really started in the 1970s with the idea of very simple, very focused goal, get the right patient to the right place at the right time. And this room is full of builders who made that into a reality. That was the driving force. There's a lot to be proud of by focusing on that simple, simple goal and making it happen, often by brute strength. Now, there's some trouble with that model. Some of the troubles is that it's designed for very low-frequency, high-impact events. But it did change the world. It led to improvements in patient care. And it's still, that model is leading to improvements in patient care with STEMI and some other things, pediatric intensive care, that sort of thing. But the problem is we're very frustrated to have a very low uptake in the market. And, you know, and it may be that the current format does not meet our emerging and future needs. So what can we do differently? Well, Camargo in his work really showed that we have this large distribution. We're talking about access being a big problem. We're looking at how fast it is to get to an ER. But you know, if you look at the size of the ERs, do you notice that the vast majority are under 20,000 visits? Now, if you work in a tertiary care center where most of the perspective is delivered on this, you really don't feel the same sort of needs or urgencies or issues or struggles or challenges as you may feel in these smaller facilities, whether it be urban, suburban, or rural. So the idea is for us to make sure that we have representation from all those. So we have people from the rural facilities and others here. But we want to make sure that we have a system that meets everybody's needs, no matter what they may be. So if you look at it, we have this tertiary urban, we have suburban, small suburban, and larger rural, and smaller rural. And if you look at how the distribution of resources are, it's interesting. Go back to Camargo's work and the AEM report that you guys put out. And you see that the distribution is about 68% of the workforce is EM board-certified, residency trained, and they tend to aggregate up in the higher, more complex organizations. And the non-board certified EM, non-EM trained are down in the smaller, more isolated, the rural environments. And the same thing goes for the specialists. There's a congregation. So not only do we have a shortage, but we have a maldistribution of the workforce out there. Okay, so we've got two issues to deal with. And you got less resources, and up here you have the bigger resources. So when you structure to get the right patient to the right place in the right time, what you do is you have a one-way valve, essentially. You've talked about not centralization, but, you know, regionalization. Currently, what we have really is a lot of centralization. We have an aggregation of resources rather than a distribution of resources. So the system works very well for that sub-select people that we pull out. Well, the trouble is that if you look at it, the resuscitative, you pull out the ones we have, trauma, and we have, let's say, STEMI or whatever, you may say overall, that's about 2% of our overall patients that are getting specialized care, or getting the care, they're getting delivered to the care. What about the other 98% of our patients? Are we doing anything for these people? Does our system take them into account? If we're talking about being patient-centered, what happens to all these people? Well, what kind of patients do we have there? Well, abdominal pain is a big number of patients coming in. Chest pain, non-STEMI, is a large number of patients we have. Fever, headache, injury. So these are high frequency, moderate impact, but actually we don't really have a system in place to help take care of those patients. So what we find is a lot of those patients are transferred up the system in order to get additional consultative care. So what's the impact of that? Well, we're finding a lot of people don't want to play because there's winners and losers, okay? So what's the economic impact on transfers that we have? Well, you know, on the patient, what's the cost of going to another place where they may discharge you, or you go to another place and you're out of your community? What's the cost on that? What's the cost in a local facility, which you may not know, but a lot of these smaller hospitals actually transfer as many patients as they actually admit. And so they lose all that revenue. And if you're a small rural facility, where remember, access to care is a big issue, we don't want to destroy them if we want a good, healthy system. If they hit a 1%, 2% margin, they break out the champagne. They really do. They're very much reliant on being able to provide care locally. So as we keep transferring patients, especially if they're discharged from that other hospital, we really haven't done them any service. And what does that do to local providers and their ability to maintain capacity and capability? And I'll talk about that in a little bit, because they lose it, because they don't take care of these patients, and then on the community. So one of the questions is, do we even measure this? Do we even measure the impacts of the systems on the community that they serve? So if you look at this right now, what's really hard is to get data about those transfers, and it's very hard to do. I've got Rick Hunt working on something for me. I went to DHHS, I went to others. In our meetings, in the IOM meeting, Alex, who was the neurosurgeon, told me that they could have they discharged about 70% of the patients that were transferred to their ER from outline for neurosurgical evaluation. They discharge, okay? We got the number from Savannah Memorial Hospital, about 70%, and also went to Grady Hospital, so it was about 70%. And I thought that was a little high. So we went over to DHHS. They went to HCUPS, which is the healthcare data that they're using, and they actually looked at the percentage of patients who were transferred from one hospital to another and then ultimately discharged from the ED, and they came up with 72%. So I mean, I'm not sure I trust that number yet, and I asked them to go back and look at that number again, but they showed me the spreadsheets and they showed me the data. But even if it's 1/3 of that, even if it's 1/2 of that, it's an amazingly inefficient system, which means that we're transferring patients up for non-interventions. There you go. The other thing that I hear a lot about is the physicians feel like it's difficult to interact with the other systems, that they call, they get kind of badgered, no one trusts them, how do I know what you're doing, you're dumping on me, that sort of thing. And so the system does not work both at an operational level, but also at the professional level. It does not build the relationships, it does not lead to increased capability to all the players inside. I mean, I got to tell you, when I talk to a lot of physicians, I work at Grady, so when the phone rings and somebody says, I can't get through, we always say, just send them, just send them over. But when we talk to docs in the field and docs in the receiving centers, there's really very little relationships. We'll often have suppers and bring people together, and what we all start off with is nobody's happy. And then you build from there, and you build those relationships. But one of the reasons why this exists is the lack of information flow. It's about what I think, what I see, and you're trying to describe it over the phone as opposed to being able to share the information. Now, this is the one we all talk about. Boy, this is wonderful. Accidental Death and Disability. That is the book. That changed everything. But here's what I want you to remember, is that there's this book that came out. This book came out in 2001. And I go to meetings a lot and I say, do me a favor, somebody give me their definition of quality. And people kind of give it that little blink, blink, blink thing, and every now and then somebody defines it with using the word quality in the definition. It's always nice. So what happened was, this is 2001, Crossing the Quality Chasm. And before that, I believe 1999 was the one about To Err is Human, which is about all the errors. And so they said, you got to have some sort of definition of quality. We have to make it happen somehow. And so this came out in 2001, and what it did was it gave you the aims of equality. And so this is what's been driving everything for the last 10 years. You see where it says effective? That's where core measures came from. That's what PQRI came from. You see the thing about timely? That's why the cardiologists got involved and the neurosurgeons got involved. Patient-centered, those patient satisfaction scores you hate so much, came from this, okay, years ago. The reason why you measure length of stay, door-to-doctor time, all these things, is efficiency measures. The reason we look at LWATs is patient safety measures. So this has been driving things over and over and over. And the nice thing is, many places are developing dashboards and metrics that say, this is what we're trying to do, let's measure that. And you can measure that at a patient level, not just outcome, lived or died, discharged, admitted. You can measure at the patient level, the provider level, the facility level, and the systems level. And in fact, many providers are getting this as measures they're using for recredentialing, correct? The other thing about that report is it gave 6 redesign imperatives. Reengineering the care processes. Try to redesign what we do. Effective use of information technologies. Knowledge and skills management. Very interesting to see that we have to find ways to build our skills and do the learning as was just mentioned, right? Development of effective teams. Physicians are not trained to be team members or leaders, quite frankly. We're taught to have your decision. It's about your decision, as if we're all going to do the Dances with Wolves phenomenon and go out there somewhere. But we need to learn that whole area about having faith in our decision making. Different set of skills than building effective teams, right? And in fact, probably the best place for teamwork is the ER, because of its nature, its fluid nature. And then coordination of care across patient conditions, services, and sites of care over time. So this book, I think, is going to be one of the big changers. Well, we go out and look at the marketplace and say, gosh, what's the market telling us? There's very low uptake of regionalization in the current form and model. And I ask the question to people, you think Apple would keep a product out in the market for 30 years if no one was buying it? The answer is no. They would change it, right? They would change it. So maybe the model's wrong. Maybe we have to change the model, not get rid of what we have, but build upon it, to tweak it, to take advantage of some of the changes we have. So look, my point is that not all change is bad, okay? Hey, I look pretty damn good when I was running at Stanford over here. But I'll tell you, see, even that change is good. It was a leap from this, okay? So there you go. So not all change is bad. So what's the challenges we have with our current systems? Well, actually, time, distance, and geography is a major issue, especially if you're in a smaller facility. Restricted access to information. You know what changed my practice? Changed it dramatically? The fax machine. When they came up with that neat little fax machine, I could see an EKG from the guy that discharged somewhere else. I could call that guy up in the middle of the night, make him go to his office and fax me something. I could get records. I had access to information, changed my ability to make good decisions. But right now, information is very restricted and locked in various parts of our systems. We have workforce shortages, and not just providers, but caregivers, nurses, mid-level providers, and others. We talked about the maldistribution. We have an aging population with a lot of chronic disease. Access to primary care is limited, and there's some concerns we're going to see a large boost in people coming to the ER because they're going to have insurance. And then the big issues, I think, raised, and I think Brent mentioned some of this, but, sustainability of our models. And then, in the Institute of Medicine, that sixth thing about equitable care, I've always said, well, look, in the ER with EMTALA, it's always equitable. But if you look at the system, it's not. In the system, in the rural places, in the places without all the consultants, even if you're not rural, you have an inequity of care to your patients there because the resources are not available to you. So there's a lot of opportunities. There's a lot of resources. There's technologies that can leverage what we do. We have a movement to electronic data, images, and records rather than just what's in paper. We have the growth of high-speed, secure high-speed and voice connections. Right now, one of the big players coming to healthcare is Verizon with their 4G network, because they believe they can do it securely and they can do it quickly and they can be ubiquitous. Move toward quality and value-based payments. They're going to pay for those 6 AIMs, and the development of health information exchanges and others, and we have people to represent that. So look at the resources. Equipment and technology is fixed, you move the patient to it. Procedural skills are fixed, you move the patient to it. But cognitive skills are mobile. And in fact, this is not new, right? We've had poison control for years. Pick up the phone and call somebody. So in that case, you can move that to the patient, and quite frankly, probably the best model of cognitive skills being moved is stroke. They bring that right to the bedside. So it can be done. So looking at electronic collaboration, and remember, integration and collaboration is a big thing now, right? Connecting providers and resources, we can actually share data, look at the patient, we can move that information. So with electronic collaboration, right now the payment models are 3 basic things: consultation, interpretation, and treatment, okay? But you can do patient care consultation, you can do patient monitoring, both at their home or at another facility and remotely. I went to the ATA meeting, American Telemedicine, 2 years ago, and everything was Bluetooth suddenly. So it'd link up with the computers, right? So now I could monitor everything. A lot of the cardiac monitors now actually plug in, they have IP protocols. They plug into the line like you would your computer. Imaging, ECG review, and interpretation, they can do it real time, or what they call store and forward, right? They send it and you download it later and give an interpretation. But here's the one I thought was most interesting. When I was first told about it, education and training. Well, you can keep training people. But what they found in telestroke, for example, is that they get a lot of calls from the ER docs to begin with, but then over time, the capacity and capabilities of the emergency departments goes up, and they can handle more things on their own. So there is that actual raising the education level of the entire system because you're distributing the knowledge. It's a real issue we should look at, because that's what we do, and certainly for SAM, this is what you do very well. Then transfer of care and treatment planning. So going back to this, here's the aims: patient-centered, safe, effective, efficient, timely, equitable. They can be measured across. Can we build something that actually may be more patient-centered, maybe safer, maybe more efficient, more effective, timely, and equitable? And the answer is certainly we can. So looking at changes, get the right patient to the right place at the right time. Driving networks of integrated networks for emergency care would be get the right resource to the right patient. Not the patient, the right resource to the right patient at the right place at the right time. And that's really the driving mantra that may build what we want to build now. So we look at abundant care resources at the top end of this, provider and patient needs throughout the system, and rather than the traditional send them up one-way valve, we look at a better way to create networks, to create not just individual systems, but networks. So extending the reach, here's some of the things that are being done now electronically, electronic collaboration. The one I didn't put on here is pathology, which I learned yesterday is actually happening in my hospital. because I never talk to these people. To me, a lot of this stuff is happening around emergency medicine and not with emergency medicine. Part of that's because of the payment structures. Part of that's where the money's coming from. Part of that's where they have a very discrete task that they can do, whereas emergency medicine is fairly broad. So the questions are, can we now find ways to link that by looking at that larger mass of individuals that we've not utilized this technology for? So these are the things that are being found every day, being used. And so we started looking at what's in the marketplace right now. Some people from Global Media here, that's one of their programs, one of their cows, really, where you can do telecommunications, two-way communications. But what's interesting now is 72% of physicians have smartphones. That was actually released at a meeting about 2 weeks ago. And so there's more and more applications to be able to transmit information. What's really interesting, by the way, is the FDA is coming into this to begin to regulate this, okay? So they're going to have to meet certain thresholds and everything else, right? But it's interesting now. If you ever go to TED Talks, you know TED Talks? It's kind of these big thinkers. There's some great talks on the future of wireless medicine. And, Eric Topol's talking, and while he is, his whole heart rate and everything else is being put up on a screen. Very small device, but it's coming now, ubiquitous. So rather than try to do a top-down approach, one of the things I argue for is that we just need to start building it locally, and it will begin to spread. That's the way Wi-Fi has developed into networks. You just start locally and spread. And I think it's going to be the same thing for our ability to build really integrated networks. And I really want to use that word integrated. And I really hate to say it, I don't even like the word regionalization because people think they know what it is. So when you say it, they go automatically to their mental model. We have to change the mental model. So I'm a big believer we have to talk about integrated networks. And the winds of change are helping us. They really are. This is from Eric Topol's talk, 10 targets for wireless medicine. Some of the things that they can actually get remote monitoring and manage. The largest provider of telemedicine right now is the VA. The VA has about 40,000 people, but they actually have one nurse can monitor and manage 150 patients a day. So the ability to distribute her is because of the technology. I think in the emergency department, if you have a very sick patient, you end up going to the phone and then you start trying to describe stuff over the phone. Being able to do electronic collaboration would make that a much more robust and rich, and the need to transfer may or may not be made, but the ability to improve the care of the patient, improve the care of the system, the knowledge of the system would certainly be there. Here's some of the players. There's a boatload of money out there that probably we're unaware of. HRSA, for example, has rural grants that do telemedicine. They can certainly help link up ones, be good for both what they call the spoke facility and the hub facility. The FCC, Federal Communications Commission, has put out a broadband plan in March that's going to look at having high speed, both wired and wireless, and part of its telecommunications. And by the way, I learned that there's something called the Universal Services something, which is on your phone bill. And they got hundreds of millions of bucks that they're putting out for building infrastructure for telecommunications, okay? Big players are in from the private space, Global Media being one, GE Healthcare, you'll hear from someone from Cisco later. Polycom is one of the larger telecommunications organizations or companies right now. United Health Group now is paying for telemedicine. You may or may not know that. They're actually paying for that. There's 11 states that are paying for telemedicine, mandated. That actually comes through the Medicaid side for the most part, through the payers. Medicare has its own way of doing it. But we need to learn more about this. And this is the really thing I think is cool. In the new bill that was just passed, healthcare bill, CMS is going to have a Center for Innovation. And so they're going to help us build new models. We just got to tell them what the model is. So, without vision, the people perish. We haven't have to come up with a model that works and addresses it. So it's all coming together. We have wireless sensors. We have pervasive connectivity. Almost all of you have some sort of connection to your email right now, okay? 3G and 4G networks. Emerging standards so things can be locked together. Regulatory changes. In fact, last week, you may have seen this, but Medicare changed its rules of participation in order to make it easier for doctors to treat patients remotely. Did y'all see that? Because there was a difference between JCO and Medicare, and Medicare found that their credentialing requirements and privileging requirements are actually a barrier to distributing physicians with the workforce problems. So you see an increased funding and payments, including HIT, which, interesting enough, emergency medicine said we don't want to play in that space. And everybody else had it changed to get in, but we still don't get it. Health information exchanges are being built, and we'll learn about that from Pat Wise a little bit more. So, and the nice thing is that a lot of this now is building in with clinical decision support, so that when the decisions need to be made, rather than have to consult, and call somebody, best practice will be there to help guide therapy. So what do we have to do? Well, you have to categorize the EDs, the patients, and the resources just to understand what those needs are and what the capabilities are. But I don't think the traditional basic comprehensive ED is the way to go. I think we've got to figure out what we're trying to do with that. Certainly patients and resources can be better. Change the driving goal of regionalization from what it was to what it should be. Match those resources and needs. Develop simple, understood model because you want it to be spread. You need to make it short and simple and sweet. What's the driving goals? What's the model look like? Deliver well-understood, reportable quality measures to measure, to monitor, deliver, and improve quality using quality measures on the patient, the facility, the system, and the population. And I don't think that's as hard as we make it seem. So what do? Well, we change the name. We change the goals to get the right resource to the right patient at the right time. At the right place, at the right time, and change the rules. Do the greatest good for the greatest number of patients, not just the small number of patients as the driving issue. Drive the value through measurable quality. We know what the aims are. Play with others, okay? Something for everyone. And I'll tell you, John Rogers is here representing the rural section at ASAP. I can guarantee you that there's a lot of people who feel they're opted out or they're just, participating when they have a bad patient, but they're not part of the system. Do no harm to those in the network. It has to be win-win, not win-lose, which is one of the barriers we have today. I think it's great for the patients, what we're doing today. I think what people have built today is fabulous, but we do have an opportunity to build on that and not be tied by that, to do even more. And leadership does count, as mentioned by my colleagues. And then lastly, change the name, change the goals, change the rules, and then change the world again. What exists today exists because of your leadership, because of your vision and your hard work. So, Brent made this one. I'm a big believer. The best way to predict the future is to create it. So we share that. But here's what I want to show you. This is a real picture of what truly exists. This started, all of this, the bridge, the buildings, the lighting, everything started because it was in somebody's head. They had a vision, they had an idea, and they made it become reality. For each and every one of you, my challenge to you is help us get there. Use your expertise and your knowledge. Look over the horizon and play well with others. And let's build the EMS and the integrated care system of the future. Thank you.
So I stand between you and your break, and I recognize that, and will be mindful of it, I promise. I want to say a few things, and then I want to sort of make clear for you your charge for the day. And my hope is that I'm going to be repeating much of what was said and helping it to be clear how we're going to move forward as we go on with the rest of the day here. So I briefly want to sort of talk about a subset of conditions that we attend to because they're, I think, our canary in the coal mine, our time-critical conditions. And I want to talk about the successes of them, but I also want to talk about the challenges that we've had in delivering them appropriately to our patients. I want to talk very briefly about the fact that there are giant opportunities coming our way, as people have alluded to, in that the research funding agenda is now starting to perfectly match what we need to happen, which is better implementation of what we know. And then I want to give you the nuts and bolts for the day. So many know this study. I will flash through a couple. This is the least researchy research meeting you've ever been to, I suspect. So I felt like we needed to put a little bit of science up here. So this is Dr. Cannon's study from JAMA 2000. It's 27,000 patients. It's time to there's door to balloon time on the x-axis, and on the y-axis it's adjusted death. And I think, sorry. I think you guys, know this story. You know that time-critical PCI improves outcomes. The cover or the lead article in JAMA yesterday or today, I can't remember when I read it, is sort of validating this again, telling us this story once again. Many of you know Manny Rivers' paper from New England Journal of Medicine in 2001, an aggressive 6-hour protocol for sepsis, aggressively drove down 60-day mortality. All done early, all done in the emergency department. Not rocket science, not anything terribly complex. Dr. Marler's study from neurology, everybody knows that originally we thought, and I apologize to the stroke researchers in the room, that the 3-hour mark was the mark where we started to see the odds of a favorable outcome cross one, which is why we have our 3-hour window for TPA. This is Ellen McKenzie, was referenced earlier by one of our speakers. This is her landmark paper in 2006 in the New England Journal of Medicine. It talks about trauma outcomes. It's a comparison of 18 level 1 facilities and 51 non-trauma hospitals. remarkably well done adjusted analyses following people out to a year after their outcomes, demonstrating for us the benefit of the trauma system, relative risk of death of 0.75 at a trauma center as compared to a non-trauma center. And then there are the 2 papers that led the charge for cardiac arrest, demonstrating to us a marked benefit for hypothermia, decreasing odds of death, increasing odds of favorable outcome. I think that's the piece that we know. This is why we do what we do. The piece that I want to refocus us on a little bit is how well we're doing in delivering that to our patients, because I think that is one of the punchlines for today. And I think that we need to understand that the next series of papers that I can't show you are the ones that Mike Handrigan desperately wants to fund over the next decade. He wants us to prove to him that we can deliver that care. So here is our lovely cardiac paper with the best data that I could find, telling us that 30+% of STEMI patients get no reperfusion at all, let alone PCI. Here is our paper for sepsis telling us, I saw Alan earlier, I don't know if he's here, telling us that 5% of patients in academic emergency departments or 5% of patients in academic emergency departments, 5% of academic emergency departments are doing early goal-directed therapy for sepsis, and maybe the number's a little bit higher on the margin, but we don't know, and we don't know exactly what that number is, but likely that number is lower in community hospitals than it is in academic departments. We know that about 3% of ischemic strokes get treated at Joint Commission certified stroke centers, and the number is somewhere less than 10% getting TPA. We know that despite the fact that the trauma system is the best celebrated of all these systems, that 1/3 of patients with major trauma, ISS greater than 15, are treated at non-trauma hospitals. And we know, based on now a little bit dated survey, that 1 in 4 physicians, with a terrible selection bias of going to academic medical centers, 1 in 4 emergency physicians had ever used hypothermia. So I think this is a very optimistic number. I think that many of you would say that the number for folks using hypothermia for people that have return of spontaneous circulation for cardiac arrest is much lower than 1 in 4. And there's other variability. This is the Resuscitation Outcome Consortium. This is Graham Nichols' paper from JAMA demonstrating to us a variability in cardiac arrest survival from 7 to 41%. For those of you that wake up every morning and read your ACEP news alerts, the second story there is one that says the language is, I lost it. Location of cardiac arrest depends largely on the neighborhood in which one collapses, or outcome from cardiac arrest depends on the neighborhood in which one collapses. It demonstrates that if you're lucky and there's a good uptake of CPR amongst the civilians in that area, if there's good access to emergency care, you do well, but it's all determined by your geography. This story, I think, people heard about when it came out in the New England Journal, demonstrating more variability for us by when you show up. This is the MIDAS group looking at all all first MIs in the state of New Jersey using Medicaid data, as I recall, demonstrating not only a difference in outcomes for weekend versus weekday presentation, but the fact that they can explain all of these by the aggressiveness of the PCI therapy. And we can tell you the same story. This weekend effect exists for stroke as well. This is a more recent paper from 2007 describing the weekend effect for stroke. So we made mention before that we have done a good job in building some effective disease-based models. One of the first to do this, of course, this is the most recent, maybe the most recent, there might be one more, but this is a recent version of the American College of Surgeons Committee on Trauma's book, Resources for Optimal Care of the Injured Patient. First written in 1976. Those of you in the room who have led this charge for the better part of your careers know this story well, know that they gave us a rule book and people followed the rule book. Well, the rule books have kept coming. We now have for acute ischemic heart disease, for STEMI, for out-of-hospital cardiac arrest, American Stroke Association for stroke. The SCCM, evidently their white paper is at the level of the board now and is about to come out, but there is a conversation about how maybe all mechanically ventilated patients should be in some way regionalized. And my central thought is that much like the parable of the blind men who are examining the elephant, I think only in medical circles do we accidentally say examining. The blind men who are confronted with feeling the elephant and trying to describe the elephant, this is a lot like what we are. We are all of our different systems, and the STEMI folks are getting really good at the pre-hospital piece, and the trauma folks are good at the pre-hospital piece, and the stroke folks are starting to demonstrate to us how technology gets us there. We're sort of stuck in the worlds that we practice in. Much of that is because of the funding environment, or historically has been because of the funding environment. But I think that we're beginning to break down these barriers, and that's my hope. Whenever I'm confused, I turn to Donald Rumsfeld, who tells us if you can't fix a problem, you should make it bigger, one of Rumsfeld's rules. And I do think that that is sort of what we're saying. Bigger for us is the reason that the conference is called Beyond Regionalization. We need to think bigger. We need to think across all the time-critical conditions. We're going to do that in our first panel. We need to think about the non-time-critical stuff, which Dr. Martinez touched on really well. It's the bulk of our business, and we don't do a great job thinking about a comprehensive plan for that. And then I think we need to think about the opportunities, and I will move quickly, but for those of you who know, the Federal Coordinating Council for Comparative Effectiveness Research spent a year defining comparative effectiveness, and this is their final diagnosis. This is their final definition. The conduct and synthesis of research comparing the benefits and harms of various interventions and strategies for preventing, diagnosing, treating, and monitoring health conditions in real-world settings. So the punchline embedded is defined interventions compared may include delivery system interventions. I see this as, I read this and I was elated for days. I see this as something for us to celebrate because they're now saying we want operations research. We want people that think aggressively about how to deliver the care to apply for funding. And you guys know the story for this. It's initially $1.1 billion and more to come. And then the last piece I sort of want to talk about is quality, and Dr. Martinez also touched on this. You can tell that we spend too much time on the phone together. But we don't know what the quality metrics are that define an emergency care system, and it's a giant challenge that's coming our way. The current paradigm, I would submit, is to think from the perspective of the hospital. And I'm not sure that fits very well in emergency care. We don't care for the patients that are in the hospital. We are more tied to our community than many of our elective disease partners. So I'm wondering if there's a way that we start to think from the perspective of the population, if we start to measure our outcomes from the perspective of the population. My colleague Charlie Brannis is in the room, and he demonstrated for us a few years ago that a large proportion of the population has access to trauma care. So this is a map of everybody using small unit analysis that can get to a trauma center in 60 minutes or less. If I show you on the next map, every county in the U.S. that has higher than the median injury death rate, it tells a story. And if I show you the overlap, you're left with, well, we built the trauma system in the wrong place, or it drove down population. From the population perspective, it drove down injury death. As a researcher, I would never assign causation, but I can't help but wonder. So our charge for today is to develop a research agenda, and I know you've been told that many times, but it's because we're a little bit nervous that we gave you lots of implementers and lots of big thinkers, and we didn't give you lots of panels of solely dedicated researchers. We gave you people that do, and we're charging you to come up with the agenda about how we measure the doers. There are partners here today from across the spectrum, the academic sector, the private sector, the governmental sector. I want to highlight our two panels that are about to come up. The first is called Lessons Learned, and we will lean on our, there are a few emergency physicians on the panel, but there are also folks from outside of emergency medicine who've been kind enough to come here today and talk with us about the big picture. And I think that we have a lot to learn from what they have done over the last several decades. And the second panel in the afternoon is about the administrative challenges. This is, to be perfectly honest, this is the piece that most of the academics, I think, know the least about. So we have tried really hard to bring in folks to help us to understand that it can't just be about taking the high road and talking about quality. We need to think about how to actually deliver quality in a way that doesn't have terrible unintended consequences of shutting down small hospitals and putting folks out of business. And I'm almost done. I want to describe to you briefly the 8 breakout groups. And I want to be clear that we intentionally did not have the 8 breakout groups happen at the same time. There are 4 in the morning, 4 in the afternoon. Many of you, I would bet 2/3 of the room or more, have been on conference calls and have been receiving electronic communication for the last few months, building what will be the outcome of this conference, which is to say the research agenda, the consensus documents that Dave spoke about this morning that are in the December 2010 earmarked journal or issue of Academic Emergency Medicine. I want to briefly talk about what these are because I'm encouraging you to please help us to make sure that there is a good spread to all the groups. So pre-hospital care and new models of regionalization, I think that most people get this one, and in fact, every time I emailed someone and said, which one are you interested in? They all said this one, because this is what regionalization is, right? It's pre-hospital bypass. Well, we would hope that the answer is no, it's not just that, but this is where people have gravitated in the past. There's a group that's run by that is partnered with the ACEP categorization task force called Beyond ED Categorization, and the hope here is that we think not just about the resources of the emergency department, but what the needs are of the patients that are sort of going to be accessing those emergency departments. We think that a fundamental building block to building a comprehensive system is knowing where the resources are, knowing where your assets are. Defining and measuring successful networks, I think, is going to hint at how we will know when we have arrived, when we can rest and say, we did a good job. And then the fourth one, patient-centered integrated networks, is, I think, for one of the first times, a conversation from the patient side of this. What do the patients want? Do they like to be flown halfway across their state so that they can be discharged from the emergency department? And if not, what do we do about that information? In the afternoon, there will be a workforce conversation. We think this is about the emergency care workforce, physicians, medics, nurses, the whole range, as well as the on-call workforce. This is, as many of you know, a growing, enormous problem in our specialty. There is a large group that has been working on the administrative challenges to novel solutions, because we think that implementation has largely been hindered by many of the administrative hurdles that people can't get past. There's a great group working on electronic collaboration. This is, I don't mean to bucket them too neatly, but I think these are largely the informatics and the telemedicine folks. Those are the two big domains they've been spending time looking at. And then the last group is a collaborative of folks who are thinking about, from the hospital's perspective, once you arrive at the facility, what do we do? If you can't stay there, how do we arrange some sort of two-way conversation so that we're not just centralizing? So I will end with that and just ask you to please, your syllabus is incorrect. We are going to take a break now while we set up a panel, but it says take a break and move to the working groups. Please don't do that. Please get a cup of coffee, and we're going to set up some slides. We're going to have some extraordinary lectures from some of our subspecialty disease partners. Thank you very much.